Hello, welcome, and thank you for joining us to this online expert panel discussion as part of the eCancer educational program titled Latest Developments in the Treatment of Metastatic Renal Cell Carcinoma. As you know, the standard of care for patients with metastatic aRCC continues to change rapidly as novel therapies and combinations have gained recently approval for different agencies in Europe and in the USA. I'm Dr. Javier Puente, and I'm a medical oncologist, and I'm the director of the Institute of Oncology at Hospital Clinico San Carlos in Madrid in Spain. And it is my privilege to welcome you to this roundtable discussion meeting focused on the management of metastatic renal cancer, held just after the ASCO GU 2021 annual meeting, where important therapeutics development have taken place. For this discussion, we have three outstanding colleagues with great experience in the management of this disease, and I think that all of you know each of them, but we can start with your name and the place of work of each of them. So, Professor Larkin, could you introduce yourself, please?
Yeah, hello, James Larkin. I'm a medical oncologist from the Royal Marsden Hospital in London in the UK.
Thank you, James. Professor James Bedke.
Yeah, thanks for the invitation, and it's a great pleasure to discuss the latest developments. So my name is Jens Bedke. I'm working as a urologist, as a uro-oncologist in the southern part of Germany at the University of Tübingen, and I'm a urologist and here the vice chairman of the department.
Thank you. And finally, Dr. Viktor Grünwald.
Yeah, hi, my name is Viktor Grünwald. I'm a medical oncologist and working in the University Hospital in Essen, Germany. And I'm actually part urology and part medical oncology. So I'm interdisciplinary GU oncology. That's the right framing actually for the title.
Oh, thank you for being here. We appreciate it a lot. And the key objective of this meeting are to gain a feedback on the recent data presented during the ASCO 2021 meeting, discussing the current and evolving advanced renal cell carcinoma treatment landscape, including treatment paradigms and novel drugs. So let me start with the first line. We have new data coming from two studies that were selected for oral presentations. One of them is focusing the clear cell carcinomas, the clear data, and the second one is focusing the non-clear cell carcinoma, this WOG 1500. So, Professor Larkin, could you make a summary of the CLEAR trial and its result, please, for the audience?
Yeah, so this is a study looking at another combination of an anti-VEGF drug and a checkpoint inhibitor in first-line clear cell kidney cancer in comparison with sunitinib. And for this study, it was lenvatinib and pembrolizumab. And again, we've seen really exciting data. I think that's the real top-line summary in terms of response rate, in terms of progression-free survival, and in as much as you can say at the first presentation of the data for overall survival, though I think that's an important issue, and I'm sure we'll come on to discuss that. So for me, really, the question is, how does this stack up against the potential other available options? And then there's no doubt this is a very strong data set, but as you've alluded to already, potentially, assuming we have regulatory approval and reimbursement, there may be choices in the near future in clinic. And I think that's the question. How do you make a choice for the patient in front of you?
Absolutely. So, Viktor, I would like to get your feedback about the how clinically meaningful is the efficacy data coming from this study at this moment?
Well, Javier, I mean, what we have seen actually at ASCO GU is really very good data in terms of objective response rates. I mean, it's really going beyond the threshold of 70%. So we have seen 71% of objective responses, 16% of complete responses, and a progression-free survival of 2 years. And actually, just looking at the numbers, these are the best numbers that we have achieved so far in clinical trials. And the question is really, I mean, how can we compare them to others? So we're speaking about cross-trial comparison, although we're not supposed to do that actually because of the limitations. We still do that because we have to pick the best choice for individual patient that is sitting in front of us. And I think it's exciting times, and there are benefits that come along with that treatment, and it is the efficacy.
Absolutely. what are the data gaps, Professor James Bedke? What is the from your perspective, when you analyze the CLEAR data, what is the weakness of these combinations comparing with another combination that we have available today, like axi-pembro or nivo+IPI?
Oh, yeah, thanks, Javier, for this question. I think it's a very, very difficult question because, as Viktor has said, data is really outstanding. So we have not observed the PFS as long as now demonstrated by the CLEAR trial. We have not observed the response rates be above 70%. I mean, it's a 16% of CR rate with a TKI-IO combination. So, I mean, you asked me about weaknesses of this trial, and I said it's difficult to point the finger to them. So I think what we need is we will need a more robust data for the overall survival. This is definitely something we would like to see for the future. On the other hand, I mean, this trial has a median follow-up of 27 months, and it's a very long follow-up, but we needed this follow-up because PFS was 24 months, median PFS for lenvatinib pembro was 24 months. So what will happen in the future? Hazard ratio for OS is 0.66 currently. I think at the end, if you have a look at the end of the Kaplan-Meier curves for the overall survival, there are some, well, smaller question marks how the curves will separate and still separated. And don't forget about the third arm in this trial. I mean, the CLEAR trial had the lenvatinib everolimus arm, and this crossed the sunitinib, the TKI monotherapy arm at the end for the OS curves. So I think this is of interest what will happen. And of course, there are many more questions: quality of life, pro outcomes, subgroup analysis, IMDC, the IMDC favorable risk group. These are all question marks to be answered for the future.
Yeah, and James, the key question is how you are going to select properly the combinations in the future. What decision-making tools and biomarker are you using in your daily clinical practice?
I wish I could say that there was something that we thought was really clinically usable in terms of biomarkers. I mean, everyone's smiling, right? We've been talking about this for a long time, haven't we? And listen, you know, if it was easy, I think we'd know the answer already, but it's not easy. It's a complicated disease, isn't it? And it's not a disease where you have driver mutations like many other types of cancer where drug targeting is by definition technically easier. So it's a shame, but there we go. It's important that we continue our efforts, though, to develop biomarkers. But ultimately, we're using risk criteria, which are pretty well established. And I think that's important. I think certainly in our routine clinical practice a few years ago, that may not have been something we used so much. But now I think with the data we have, and maybe this brings us on to a discussion of ipi/nivo, you know, one of the things you really want to know is what is the risk group of that patient in clinic, and particularly in intermediate and poor risks, you know, what's going to be the right treatment option. And just to pick up something that Jens was just talking about, data gaps, you know, for me, for clinical trials, a big data gap is always by definition, how does that translate to the patients we see in clinic, right? Patients who go into trials, there's a subgroup of patients in all our practices. You know, so for patients with poorer performance status and comorbidities, you know, I want to know how we can use this treatment. Can you salvage bad disease? Is the toxicity worse? So I think that, you know, to some extent, there's always a gap between clinical trials and routine practice.
Absolutely. Viktor, we have another data coming from the great phase 3 trials, the KEYNOTE-426, and the ipilimumab trial and the cabo-nivo trial in the first line. And the 3 studies have communicated during this ASCO GU several data that they are very interesting. For example, the KEYNOTE-426 have presented the outcomes for patients who completed 2 years of treatment. How do you think about this strategy to stop the immunotherapy after 2 years of treatment?
Yeah, Javier, I think it's a very good question. And it's great that we have it implemented in our clinical studies, because I think overall it is palliative treatment. And there at the end, it's the balance between efficacy and tolerability that makes a difference. And what I used in my clinical practice for the past 10 or 15 years is really to discontinue therapy where it's when it is appropriate. So the question is, you know, once you treat it enough, you could stop therapy and maintain the therapeutic response. I mean, that's kind of the idea, at least. And in the pembro studies, it's set at 2 years. So is that a good mark? That would be my question. I think, I mean, there's some debate about it, but I'm glad that we have such data, so we can look at this. And so in that study, actually people stopped after 2 years with the infusional rates of pembrolizumab, and overall survival rate has been at 3 years then 49%. So that's great, actually. It kind of tells you that those responders, they do just excellent. And there is a decay in terms of the events in terms of progression, but those patients usually can be salvaged with proper, subsequent line of therapy. So I'm not too worried about that. So I think it's very informative. It strengthens the point that you could stop therapy during the course of palliative therapy. And I think we should investigate more which patients, can be safely stopped and taken off therapy.
Yeah, absolutely. And Professor Bedke, the CheckMate 9R has published the outcomes for those patients with sarcomatoid histology. And how do you manage those patients in your daily clinical practice today? How do you see these results of this trial in this population?
Well, I think it's important that we now got data from CheckMate 9ER that it's also active, the Cabo-Nivo combination in the sarcomatoid subgroup. And this is in line with the results of the KEYNOTE-426, also of Javelin, Renal 101, and also of CheckMate 214. And it's probably the introduction of the IO agent in this combination for the treatment of sarcomatoid patients. So, well, you asked for the clinical routine or for the clinical impact. I think, first of all, for this special subgroup of patients with sarcomatoid features or histology, we need a combination therapy which is IO-based. And then you make the second choice if you use ipi/nivo or if you use a TKI-IO agent. And the CheckMate 9ER data is in line with what we know from this sarcomatoid subgroup. Well, personally, the data presented from 9ER, this subgroup analysis was a rather small subgroup which we observed. And maybe this is also why the PFS rates reported were a little bit or slightly lower if directly compared in a cross-trial comparison to the other TKI-IO combinations.
Okay. Let's move to the non-clear cell carcinomas. And James, how about this group of patients? How do you see the raising data coming from the SWOG 1500 trial, comparing Cabo versus savolitinib versus sunitinib? How do you see these results? And what is your daily clinical practice with this kind of patients?
Yeah, I mean, I'd say that these data were encouraging is the first thing. And a general comment would be that anything which is looking to segregate non-clear cell kidney cancer is important, because, non-clear cell kidney cancer, quote unquote, clearly isn't one disease. It's multiple different diseases. So I think the closer we are to actually trying to define the subsets accurately and to develop treatments that are actually based on biology, and I think that's what we're beginning to see now, the better is it going to be for our patients. So I think this does definitely represent progress. I mean, I can still remember 10 or 15 years ago where we were putting everybody on Sutent with non-clear cell histology, and now it's looking like we've got slightly more rational options. But, I would still say that there's a lot to do for this group of patients in general. And the trials are difficult as well. We all know that. I mean, papillary find, 10 or 15% of patients. But once you get into some of the rarer groups, even chromophobe, you really need to do multinational trials to try and get any traction on it. But again, I think it comes back to biology, and the better we can understand that and rationally target treatment, the more progress we'll make.
Hopefully. Let's move to the second line treatment. Viktor, what is your impression about the clinical study data of the Lemba combinations in previously treated with advanced renal cell carcinoma? We have in the past the phase 2 trial comparing Lemba everolimus versus Lemba versus everolimus alone. A very small trial, but we have at least one big trial with more than 300 patients. How do you feel about the results of these trials with these two schedule of treatments with lenvatinib?
Yeah, I think something that we always complained about is that HOPE-205 is such a small study, and we're having an approval based on 51 patients, which was exceptional at the time being. So, so did we succeed? Nowadays, I mean, indeed we did. We now have a much larger database to chew on, actually, and digest. But still, it's randomized, yes, but the control arm is Len-Ev versus Len-Ev. So, I mean, did we really, that doesn't really change our practice. I think, I mean, for my taste, it does, because we now have more than 300 patients from this study and that we can look at. And they all had the same type of therapy, which is Len-Ev and the combination. And I think what we have seen is that we kind of mirrored what we have seen before in the smaller 51 data set study in HOPE-205. So PFS of about 1 year, objective responses about 40% in the independent review process. So I think it is very reassuring, and there's no additional safety signals. So I think that is a very potent combination to be used after TKI failure.
Mm-hmm. And what about those patients that have received immunotherapy before? What is the standard of care, and what is the position of Lemba in this context, Professor Bedke? Do you think that these combinations could be useful in these populations that have been treated before with immunotherapy?
Well, I personally think exactly what Viktor has said. So we now have a whole big database for Len-F in the second-line setting, and we do not have to rely on a 50-patient subgroup based on this phase 2 trial, HOPE-201, 205, and which led to approval. We have to admit that. So I think what we learned from the study 218 is that a combination is also feasible and appropriate in the second-line setting. And it's the first combination in the second-line setting we now really have available in our hands. And of course, it's a combination which can be used after IO therapy in the first-line setting. So, I mean, we know we do not have an IO agent of Len-F in the second line. So we do not have to answer the question of the IO activity in the subsequent line if it was given in the previous line in the first-line setting. On the other hand, to be more broadened, we know that based from the KEYNOTE-148 trial with lenvatinib pembro in the second-line setting, that we have activity of a second IO agent in the second-line setting after IO pretreatment. All right, directly related to the Len-F in the second line, for me, it's a strong signal to form a combination or combinatory strategy also in the second-line setting.
Okay, great. And James, at this meeting, Dr. Rennie presented the result of the TIVO-3 trial testing tivozanib in patients with aRCC that have progressed before to axitinib treatment. How do you see this trial? This is something relevant or not in the daily clinical practice?
Yeah, I think it's difficult to say, actually. I mean, control arm is sorafenib, not really a drug that's that widely used anymore, although I appreciate there's probably a bit of geographical variation there. And, 15 years ago, sorafenib was great because it was one of the first drugs, but it's relatively toxic, sorafenib. Tivozanib is a cleaner drug. The toxicity is more manageable, I would say, and it's nice to see that tivozanib is superior to sorafenib, but we kind of knew that already, I think it's fair to say. Yeah. What's the place in practice? Well, I mean, I think, for my money, most patients, again, assuming reimbursement and so on, are going to get a checkpoint inhibitor therapy in the first line. And then in the second line, I think you're going to be looking at things like Cabo, Len-Ev, other possible options. So beyond that, well, number one, how many patients are getting to third line? Yes, some do, but it might only be 10 or 20% of where you started off from. Mm-hmm. But I think to have a relatively well-tolerated clean agent with efficacy in that situation, I think, that has some merit, actually. And we know that there are patients, who end up in that situation. So, yeah, I think there is some potential utility there, but perhaps not enormous, shall we say.
Absolutely. What is the optimal treatment of the current approval treatment, Viktor, in your institution for those patients that have treated before with a novel combination of therapy with NIVO+IPI or with TKI plus IO? What is your current treatments that they are using now?
Yeah, I think that's a very good question, because that really relies on the approval status of a given drug. And whether you can prescribe it or whether you are, not able to. So there is huge variability, I would say. And I think that's also something that we have seen from the data sets from real world practice at ASCO GU. So there is a dominance of cabozantinib, and that's what we do as well. I mean, we use cabozantinib preferred in that setting. But, after seeing the data with Len-Ev and knowing that 1/4 of the patients in that particular 218 study had also exposure to IOs, I think we may have to reconsider on how to position ourselves in that scenario. And there's the pros and cons having a randomized trial with cabo versus everolimus with a benefit in overall survival, whereas, you have Len-Ev with randomized trial, but not the proper comparator, which would be cabozantinib, for instance. So these are my main options in second line, and how we set it up or did set it up in the past and will in the future.
Yeah, I think that we have enough time to discuss some data coming from novel therapies, and I think that belzutifan, the MK-6482, is a novel therapy that they are very impressive in different trials. And this year, Dr. Bauer presented the data coming from the preliminary results of this trial as monotherapy, and Dr. Chueri examining the combination in combination with cabozantinib. Professor Bedke, how is your insight with this kind of drugs, or alone or with combinations in metastatic RCC?
Well, I think it's a very important agent, which we now can use in clinical trials, and hopefully later on in the clinical routine setting, once it should be or would be approved in the future. Nobody knows how then this will be, but I mean, we talked about sunitinib, and that we started sunitinib treatment in almost every patient like 10, 15 years ago. Then we started IO treatment, and now we have a TKI-IO treatment, combinatory treatment. And I think the most important message for me is that we have a new field, a new drug class, which can now be used in mRCC treatment by this respective HIF-2 alpha inhibitor. I mean, the data is very promising, but what we observed from the data, especially from the abstract from Dr. Bauer, is that we have a high rate of stabilization of the patient. That stabilization, continues, but the rate of response is lower. And what we do not know actually right now is how long will the stabilization of stable disease and the decline of the tumor diameter will need or will happen. Because data and follow-up is too short currently. And I remember just Dr. Correa's presentation where he combined cabozantinib with MK-6482, and what remained in my mind, several times he pointed out it's a preliminary data. Yes, of course, it is preliminary data, and this is why we have to judge this with caution. How effective this combination, for example, will be. I have no doubt that MK-6482 is an active agent, but the future will answer this question in an exact manner.
Absolutely. And James, what the future looks like with this drug, for your opinion?
Yeah, I mean, I agree with what Jens just said. I mean, it is great to have a new class of drug, right? I mean, that's a big deal because we've been using anti-VEGF and checkpoint inhibitors for a little while now, and of course, there's mTOR inhibitors as well. So I think that's important. I think the science is fantastic behind this, really, really exciting. Goes without saying. But, frankly, the question is going to be how it stacks up in randomized trials against, benchmarks, whatever the benchmark's going to be. I mean, it's good to see the combination data, but ultimately you can combine drugs. It's just a question of what the dose and toxicity ends up being. But, what I'm interested in is, is there any overlap here in terms of efficacy for the agents that we have already and we know about already? And and as we've said, I think we need to see some randomized data to get some traction on that, I think. But it's really exciting to see a new class of drug.
Absolutely. Viktor, finally, what are your expectations for the next couple of years in the treatment landscape of the metastatic RCC? What are you expected on?
Well, I think that's kind of the crystal ball approach, isn't it?
Yes, absolutely.
Okay, I mean...
you got the question, Viktor, yeah?
So I think, I mean, what we really have actually seen is the first wave of IO combinations coming through, and so far it is very exciting because we have much more punch in the first line, so there's much more efficacy. We lose less patients in the first line setting, so we have less early deaths to occur with the TKI-IO combinations. I think that's what we see in those clinical trials. There is the HIF inhibitor that is coming to clinic. So to find out, single agent use, combinational use, I mean, we'll see how that goes. As James said, I mean, it's probably too early to tell. There's some early signs of activity. So what is being next? And I think something that James already said is we need more diversification. So let's say we should stop speaking about non-clear cell carcinoma, for instance. We should really relate to the individual diseases and then find the right treatment. It is a challenge, definitely, but it can be done. And I think that's what we have to do and to focus on these kind of novel aspects. And something that is, already cooking is what is the next wave of immunoagents, and apparently is much more difficult to find than we initially thought. And we have to better understand right now, I think, what is the driver here for response or resistance for immune mechanisms, and then come up with the proper choice of the second generation immunoagents. But so far, I could not really predict which one will be flying.
Yeah, absolutely. It looks like we have covered the main items on the agenda. I would like to say thank you for your value contributions. We appreciate a lot. Thank you a lot, all of you. And I would also like to thank for your attentions and the eCancer team for organizing these debates. Thank you so much.